Good evening, everybody. Again, my name is Huie Lin. Welcome to the second day of the Adult Congenital Heart Awareness Week here at Houston Methodist. Today, we're going to be focusing on electrophysiologic issues and atrial arrhythmias in adult congenital heart disease. As with all this week and this week's DEBAKEY CV Lives, each of these events is available for continuing education credit. Here on our screen, you can see how you can get continuation education credits for nurses. And here you can see how you can get continuing medical education for physicians. As with all of our activities, evaluate the activity by Monday, November 8th. Print and download your certificate in PDF format, and then you can get your continuing medical education credit. If you want to participate in one of these events where we're moving towards more and more patient-centered education in adult congenital heart disease, join us on our educational advisory board. You can participate in the activity, or you can ensure that the ideas and the interesting topics that you want to talk about will be evaluated and considered and discussed during one of our DEBAKEY CV Lives or during the Adult Congenital Heart Symposium. Finally, we were recently awarded a grant from the Patient-Centered Outcomes Research Institute, PICOR, to build a roundtable of adult congenital heart disease stakeholders here in the Texas and the three-state area. If you'd like to join us, we need your help. Sign up here by emailing scachdcollaborative@houstonmethodist.org. Well, I'm really thrilled to begin tonight's discussion on atrial arrhythmias and adult congenital heart disease. And as always, if you'd like to join us in this conversation, we'd really like you to join us as well. Join by web by going to pollev, that's POLLEV.com, and enter DEBAKEY, that's DEBAKEY, or join using your phone by text messaging DEBAKEY to 37607 and send us your questions, because we really want to make this as interactive as possible. Well, I'm really absolutely thrilled to have two of my favorite people here in the studio with me today. Dr. Amish Dave, who is my partner in electrophysiology, who has a special interest in adult congenital heart disease and has taken care of a number of our patients and the very complicated congenital heart and arrhythmic issues that come with congenital heart disease. And then to his right is Dr. Randall Wolf, who is a cardiac surgeon and director of our surgical arrhythmia specialties. And then coming to us through Zoom is one of our patients, Mr. Thomas Erdos, who is really, in a lot of ways, an expert on adult congenital heart disease and atrial arrhythmias. So starting with Dr. Dave, can you get us kicked off?
Yes, thank you for having this forum for us and for the patients and for Mr. Erdos. I would like to start off by really just introducing a little bit of the topic of atrial arrhythmias in congenital heart disease. I have just a few slides. Most of this forum is really going to be a discussion and hopefully interactive. So I'm going to start with really some definitions. What is atrial fibrillation? And really, atrial fibrillation is a catch-all term, but most directly what it refers to is an arrhythmia where the upper parts of the heart are squeezing many times for every time the bottom of the heart squeezes, and in fact trying to fire 300, 400, 500, 600 beats per minute so fast, in fact, that human heart muscle doesn't squeeze. The heartbeat in a patient who has this arrhythmia is going to be very irregular, and usually it'll start off as fairly fast and uncomfortable. There's a closely related arrhythmia to atrial fibrillation that is called atrial flutter, technically. In congenital heart disease patients, we sometimes use a synonym for this called intra-atrial reentry tachycardia. But in general, this is in many ways encompassed by the term atrial fibrillation. It's more regular than atrial fibrillation. If atrial fibrillation is a thunderstorm where one moment the wind is coming from the east and the next moment it's coming from the west, in flutter it's more like a hurricane where the electricity is going in some kind of a loop or circle just so fast that electricity doesn't move. In this diagram you can see a spiral of electricity going around and around a spot in the left upper chamber of a heart, actually Mr. Erdos' heart. Now, atrial fibrillation is a very common problem, surprisingly common problem in the adult population of humans on this planet, but in the United States, it affects about 3 to 6 million American adults. About 1 in 4 adults who are right now age 40 or older will develop AFib at some point in their lives. But most of the patients who don't have congenital heart disease wind up getting atrial fibrillation in their 70s or 80s. There are many adults alive today who have congenital heart disease. In 2010, there were about 1.4 million adults in America with congenital heart disease. And given the population of the United States at the time, that means about 4 in 1,000 adults had been born with congenital heart disease. And up to 50% of those individuals will develop atrial fibrillation or flutter in their lifespan. Matched for all of the other conditions, including their age, a person who has congenital heart disease has a 22 times higher risk of developing AFib. And by age 42, about 1 in 12 patients with congenital heart disease will have developed atrial fibrillation or flutter. 1 in 10 of those patients who have both congenital heart disease and atrial fibrillation will wind up developing heart failure. And the risk of the atrial fibrillation is proportional to the complexity of the congenital heart disease. So there is another distinction between congenital heart patients and non-congenital heart patients. The patients who have congenital heart disease tend to have AFib at a younger age. They're much more likely to have atrial flutter than atrial fibrillation, although they eventually go on to also develop AFib. And controlling for all other risk factors, they generally have a much higher stroke risk than patients who don't have congenital heart disease. So really, when we have a patient who has AFib, we do wonder a little bit about what made them develop it and why they're having it. We really have to spend a lot of time worrying about what are we going to do about it. And really, there are a few things that we focus on. The first is we have to prevent those patients from having a stroke. This is really one of the major worries in these arrhythmias. The second is when these patients have their heart going so fast, it's very uncomfortable and it affects their organs and affects how their blood pressure is. We want to slow that heart rate down. And the third is we usually will find that especially patients with congenital heart disease feel much better when they're in a normal heart rhythm. And so we want to restore them back to normal, at least for that moment. And then the fourth thing is we'd like to prevent them from having AFib again in the future and hopefully cure them of it. So this will be brief, but we're going to talk about what are the options for these options. What are the options for these problems? So the preventing stroke part of it, the mainstay is basically pills. We have blood thinner pills, and if your risk of stroke is high enough, then it is almost always justified to take these blood thinner pills to try to prevent a clot from forming in your heart that could later go to your brain and cause stroke. There are surgical treatments that Dr. Wolf will explain a little bit more about that are very effective at reducing the risk of stroke. And we now know from recent clinical trials that if your risk of stroke is high enough, even on a background of being on the blood thinner pills, getting these types of procedures and surgeries can further reduce the risk of stroke. There are catheter-based procedures that are new. This was first FDA approved in the United States in 2015 that involve without a surgery but going through the groin into a blood vessel, we can put a plug, which is shown over here, into the area in the heart that leads to clots and stroke and otherwise prevent or reduce the risk of stroke that way. In terms of slowing a heart that's beating too fast, the mainstay here is medicines, pills, and there are many of these pills that we use. The tolerance for a lot of these medicines is a little bit limited in patients with congenital heart disease, so we're not quite as free to give them the types of drugs or the amount of these drugs that we might for a person without congenital heart disease. To restore a normal rhythm, sometimes we can just wait. That's option one. Obviously, it's easy. If a patient has these arrhythmias, sometimes they come and go, and just waiting another hour or two, they may resolve on their own. When that's not an option, sometimes we can shock that patient back into a normal rhythm. Obviously, we put the patient to sleep so they don't feel the shock first. Most patients who have an atrial arrhythmia of this sort will probably at some point in their lives have to undergo this procedure, and this will be something we can talk a little bit about. And, there are medicines that can convert an arrhythmia from AFib or flutter into a normal rhythm, not just slow it down, but actually go back to normal. But most of the time, these medicines are a little bit risky, usually a little bit riskier than cardioversion, and especially if you have structural heart disease, as is the case in congenital heart patients, they're usually shied away from. In terms of curing the atrial fibrillation or flutter, or at least suppressing it, there are medicines for that too, and some of these are actually fairly well tolerated among the congenital heart disease adult population. They're generally not meant to be curative. Even the best of these medicines reduces but doesn't eliminate the arrhythmia burden. There are procedures that we'll talk a little bit about called catheter ablation procedures that we do in the cath lab in the hospital that involves going into the bloodstream and burning the areas in the heart that are responsible for these arrhythmias. And there are surgical ablation procedures. Oftentimes these are considered at the time of congenital heart disease repair surgeries or afterwards that can cure the AFib. So to discuss this further, we would like to introduce a patient of ours, Tom Erdos. And Tom, do you mind introducing yourself?
Sure. First off, thank you for letting me participate today and to share my story and maybe provide some color commentary along the way. I was born with congenital heart defects. I had open heart surgery in 1964, and I had atrial septal defects that were repaired. I had a partial anomalous pulmonary venous return where one of my veins was going to around the heart was going to the wrong location, and that was corrected. They did not correct a ventricular septal defect, and they did not correct a congenital malformation in my aorta. But I was sent on my way, and roughly 50 years later, I was in congestive heart failure. I met Dr. Lynn in my room at Methodist Hospital where I was being treated for heart failure, and introduced himself as a specialist in congenital heart disease. And I cried. I thanked him for God giving him the desire to specialize in me. Up to that point, I did not know that I was one of a relatively large community of adults with congenital heart disease. I thought I was the exception, that I had survived my childhood, and many or most did not. So I was very ignorant about what was actually going on with me and with congenital heart disease in general. About a year later, I started to develop atrial fibrillation, specifically atrial flutter, as Dr. Dave described it, also known as intra-atrial reentrant tachycardia. I did not know I was in atrial fibrillation. I was in Dr. Lynn's office. He did a EKG, and there it was. I'm in atrial fibrillation. That's when we found out about it. It didn't affect me. I didn't even know I was having it at first. It came to totally affect me to the point that my heart would rate up to 150 beats a minute. It was debilitating when I had episodes. Wiped me out. All I wanted to do was go to bed. It was painful. My back, where adjacent to where my heart is, would be sore. And so I went through most of the procedures that Dr. Dave just outlined. I had cardioversions where they sedate you. First, they actually do what's called a transesophageal echocardiogram, where before they shock your heart back into rhythm, they need to make sure that there are no blood clots that have already accumulated in the left atrial appendage. This is a little adjunct to the left atrium, a little bit like the appendix in the intestines, where if the heart isn't beating constantly, which is the case with atrial fibrillation, then blood can clot in this area. And then when you shock the heart back into normal sinus rhythm, that blood clot can then travel and migrate up to the brain or into the lung, wherever it may go. So I've had 8 cardioversions, about the same number of transesophageal echocardiograms. The results of cardioversions were basically they would work for a while, and then it got to where it wasn't working. And then I had an ablation. An ablation is a procedure where Dr. Dave came in through my groin and identified through mapping areas in my heart where there were abnormal circuits. He showed an illustration of what one looked like earlier in the presentation. The abnormal circuits that I had came from surgical scar tissue from 1964. And as I understand it, the electrical impulse traveling through the heart would try to pass through a scar, maybe where one of those veins had been located and had been moved, and it would run a circuit around that scar instead of traveling onward. And that circuit would continue. And that would cause the muscle tissue there to vibrate, which would be the atrial fibrillation. According to Dr. Dave, in my first ablation, the mapping, I lit up like a Christmas tree. And it was clear that I had more issues than could be handled in a single ablation. Ultimately, over a 3-year period, I had 4 ablations. And we got to the point where I tried various medications. They were helpful, in particular, to cardiovert me at times. Sometimes they would, sometimes wouldn't. When they wouldn't, I'd come into the hospital. Ultimately, I had an implanted device to monitor my heart rate. It was just a monitoring device about the size of a thumb drive. Eventually that device showed that my heart was stopping between beats long enough for me to pass out, which made it a risk for me to drive. And at that point, I became an immediate candidate for a pacemaker. And the pacemaker that I received contained an algorithm that tries to control the pacing of my heart when atrial fibrillation is trying to cause the low chambers, the ventricles, to beat rapidly. The pacemaker algorithm controls that and tries to keep that in check so it doesn't happen. The second benefit of the pacemaker for me was that stronger medications, in this case dronedarone, I could be put on those without the risk that they would stop my heart because the pacemaker would keep my heart going. So a couple of years ago, after 3 to 4 solid years of problems with atrial flutter, any procedures, I received a pacemaker. It works. I went on dronedarone. One of the advantages of this, I skipped. And I've not been having the issues with atrial flutter that I've had for a long time because of this treatment. In the midst of all of this, I was on blood thinners for a very long time. I did not like to be on blood thinners. I don't think anybody does. Not long after I went on Xarelto, I went across the street to my neighbor that their German Shepherd was out, and the dog came within a couple of feet from attacking, and he stood there barking at me viciously, and all I could think of was, well, I'm going to die on my neighbor's driveway. The dog did not attack me, but when you're on blood thinners, you have this constant reminder that if something happens and I really start bleeding, it's going to be bad. So eventually I received the Watchman device, which Dr. Dave showed in one of his slides. It's a catheter balloons and forms a blockage over the opening of the left atrial appendage. So that area is now walled off from the rest of my heart. I can no longer have a blood clot form in that area. Well, certainly I can, and there probably is, but it's not going to migrate anywhere else because it's walled off in the atrial appendage away from the rest of my heart. With that, after time, I was able to come off of the blood thinner and only go on low dose aspirin, which was per the recommendation of the manufacturer of the Watchman device. So it's been my story. I did not have surgical intervention. My journey may not be over. That may still happen. And what I've learned is a step journey. Dr. Dave was kind of my tour guide on this journey. I can't say that it's over. Everything is under control at the moment, and that's the best that I can say. So with that, I'll turn the program back over to Dr. Dave or Dr.
Can I interject for a second here? I think there's a lot to talk about with Mr. Erdos' case. The first thing that I want to bring up is this question of what is intra-atrial reentrant tachycardia. We use that word a lot, and Tom brought that up. Can you guys talk a little bit about why that happens and why this is such a problem in adults with congenital heart disease?
Yeah. So everything I say applies to flutter just as well. Think of them as synonyms, but and I have to just explain a little bit about just how electricity works in the heart. The heart you can think of the upper chambers of the heart like a pond. When there's a heartbeat, there's an electrical wave that spreads through the pond, just like when you drop a pebble into it. And as the wave spreads, as any muscle fiber gets touched by that electrical wave, it starts to squeeze. In a normal heart, the heartbeat starts, the electricity spreads throughout the muscle squeezes, and then the whole chamber of the heart is silent, waiting for the next heartbeat to begin. When you have areas of scar, even valves that we have, that all of us have, they represent sort of like holes in that pond. In a normal person, soon after birth or during a normal young adult phase of your life, if a wave of electricity tried to go around some of the natural obstructions to electricity that we have in our hearts, that all of us have, like one of the valves in our heart, the electricity travels so quickly and smoothly through that muscle that by the time it gets to where it started, the muscle's not ready to fire again. You cannot have intra-atrial reentry or flutter in that type of person. What happens to people without congenital heart disease and people with congenital heart disease is as we get older, things happen. As the upper chambers of the heart stretch, we don't really form new muscle fibers. So as muscle fibers get separated from each other, because of the growth of these chambers, there's usually scar tissue in between that slows the passage of electricity. The wave doesn't travel quite as fast. Eventually, it can be possible for a wave of electricity to go around, for example, a heart valve, and when it makes the full circle, it will have taken long enough eventually that it can go again and go again and go again, and that is flutter. That is the most common kind of flutter. Now, with surgical scars in many patients with congenital heart disease, or ablation scars for that matter, it is possible for people to have slow electrical conduction near the scars, slow enough that it can complete a loop. And then you can have this type of arrhythmia. So that is intra-atrial reentry tachycardia. When there's a lot of surgical scar involved, we usually call it intra-atrial reentry tachycardia. And in the congenital heart disease population, that's the term that's typically referred to. But it's basically the same disease process and same treatments and same pathology as atrial flutter, which is what you'll find on Google for this type of problem.
So, and then Dr. Wolf, can you comment on, are there any things that we can do to A, anticipate that somebody's going to have intra-atrial reentry tachycardia, and B, prevent that during the surgical process?
Not that I'm aware of. It's ironic that atrial flutter results from scars, yet our treatment generally is to create more scars. Both from the catheter side and the surgical side as well. And I think one thing that helped me understand arrhythmias is that we're made up of mostly water. I think we're 70% water. And we're very good conductors of electricity. A scar has no water in it, and that's why it can stop abnormal conduction of electricity. It can promote it, particularly if it's not a complete scar, a partial scar. But a complete scar should have no water in it, and the electricity then can't pass through there. So for those of you out in the audience, that's one thing to remember, and you'll know more than most physicians know about arrhythmias, and that is scars don't have water in them, and they can stop an abnormal rhythm. We also have a heart here. I brought a heart in here, and maybe you should explain to them just in simple terms the area of the heart that we're working on, that you work on every day. And also a patient pointed out the appendage, which you can see here on this model.
This is really nice to be able to see it. Now this is a heart this is a model of a heart that doesn't have a congenital heart defect, but the types of defects that we are dealing with in some patients, there is the possibility of a hole in the membrane that separates the right and left lower chambers, the right and left lower chambers. That's a ventricular septal defect. Some people get those holes treated and closed surgically. Some people, we can, if the holes are small enough, we can put plugs in them. There are two upper chambers. There's a left upper chamber and a right upper chamber, and this is really what we're going to be mostly talking about today. These chambers of the heart have pouches coming off of them in people and in many animals. This is the pouch coming off of the left upper chamber, and these pouches don't serve much of a purpose in humans. They're the vestige of what really anatomically or under a microscope should be the upper chamber. In humans, the left upper chamber has been mostly replaced by the venous tissue. These are the four veins that are carrying blood from the left and the right lungs into the left upper chamber of the heart. The left side of the heart receives red blood from the lungs and sends it off to the body. So most of the volume of that left upper chamber of the heart is really dominated by what used to be venous tissue. When we have AFib or flutter, this pouch, as Mr. Erdos, I almost called you Dr. Erdos, was referring to, when you're in these arrhythmias, the upper chambers are squeezing so fast that really they're vibrating. I think when you look in the operating room, you see them quivering and not actually squeezing. For most of the volume of that chamber, it's sort of okay. It just means they don't push blood. But that pouch is a dead end. And when it is filled with blood and not squeezing it, that blood is stagnant, and normally blood that's stagnant wants to form a clot. So what Mr. Erdos had done was we put a device that plugged up that pouch from the inside. This is one of the ways that we can hopefully prevent stroke. What that plug does is it's made of a membrane that eventually grows your own heart tissue over it, and so essentially blood can't go in or out of it. until that happens, until the heart does grow a tissue layer over it, we have to keep people on blood thinners for several months in general. But once that process is complete, in theory, if you stop the blood thinners, at least in the very large clinical trials and now real world 6 years of experience, the risk of stroke goes down to what it would be like if you were taking the blood thinners every day. For arrhythmias, there are flutter arrhythmias, and these are, in congenital heart disease patients, usually in the areas of the heart that are affected by surgical scar. Now, there's scar and then there's scar. We know that if you cut through the heart with scissors and you sew everything back together again, electricity will never cross that. But adjacent to where a lot of the incisions happened, or where fibrosis happened through the process of normal aging and an expansion of the chamber sizes from internal pressure, the electrical signals are able to propagate because there is still some water. It's not truly all homogeneous dead tissue, but it goes slowly. So the picture of the flutter I actually showed was a spiral of electricity going like this. Now, for many people who have congenital heart disease, what really makes this fairly interesting is that the arrhythmias are not randomly distributed throughout the upper chambers of the heart, and they're not exactly the same as what other people have. They're usually fairly individualized, and so to explain what was happening with Mr. Erdos, he had surgery in 1964 to correct a problem, and the problem was that this vein didn't connect where it was supposed to, but rather drained into a vein carrying blue blood to the wrong side of the heart. And so a good amount of the lung was wasting its effort putting oxygen into blood and then having it go back to the lung again. This had to be fixed, and it was, and the vein was now correctly draining blood back into the left upper chamber of the heart again. But to do so, there had to be some incisions around the left side of the heart. And actually, almost all of the arrhythmias were focused in that vicinity where the surgical scar was. The limitations of the ablation were that we noticed early on that it was taking a fairly long time for electricity to get through the slowly conducting areas of tissue in the heart in that area. And what we don't want to have happen in most people is to prevent electricity from ever getting to that left upper chamber of the heart. If we prevent electricity from ever getting there during a normal heartbeat, then that pouch will never squeeze, even if you're in a normal heart rhythm. And most of us feel that would increase a person's risk of stroke unacceptably. So especially back in 2015, when we had limited options for closing off that pouch, we were really struggling with trying to make sure that we prevented the electrical arrhythmias that were involving that area, but we didn't burn so much that we essentially isolated it. But what actually wound up taking care of most of Mr. Erdos' arrhythmias was essentially burning enough that really was completed. Since then, his arrhythmias have been fairly minimal and fairly well controlled with the pacemaker and with the medicine. But once we did that, we were then obligated to do something, which is the Watchman device, to prevent clots from forming in that appendage. Again, that was approved by the FDA in 2015 and was still fairly new back in 2016. It's only by about now that we have a fairly good amount of experience with that device in patients with congenital heart disease. So flutters are fairly individualized. Some patients have Fontan surgeries, corrective surgeries that reroute the blue blood from the veins of the body to go directly to the lungs without any muscular tissue squeezing them. And those patients have quite extensive scar, and even if you compare one patient with a Fontan corrective surgery to another patient with the same type of surgery, the flutters that one patient will have will be fairly different from another. So that's what makes the topic of arrhythmias in congenital heart disease fairly interesting. It's fairly individualized.
A common question from patients is, you close the left atrial appendage, which did used to be called the left atrial appendix a long time ago, because it's like an appendix. And they say, why don't you close the right one? Why only the left? And the reason is, if there's a blood clot in the right appendage, which is less common, it has a broader base, different anatomy, that blood clot would go to the lungs. It would not go to the brain. And we all have enzymes in our lungs that automatically break down some clots that go to the lung. But if the clot leaves the left atrial appendage, it usually goes out the aorta if the congenital heart problem has been fixed, and the first branches from the aorta go to the brain. So then the heart problem is not just a heart problem, it's a brain problem too.
Right. And the left atrial appendage is oftentimes fairly long and thin and slender. The tip of it can extend quite a bit. It can be really more like long fingers and
like an appendix.
Like an appendix, yeah. and really have a lot of stasis of blood flow, fairly different from the right atrial appendage. So we don't see so much clinical problems with the right atrial appendage.
So there are a couple questions from the audience. The first one is a question about hypertrophic cardiomyopathy. So it's a 62-year-old man with hypertrophic cardiomyopathy who's had 3 ablations that were not successful, and then had 3 cardioversions. I think we lost some of the question, but I think probably the question is, what exactly happens in things like hypertrophic cardiomyopathy that predisposes patients to atrial fibrillation? And then I guess the second follow-up question to that is, what exactly happens to a lot of our patients, like Mr. Erdos, that predisposes them to atrial fibrillation? Because as you mentioned, multiple situations that a lot of our patients develop atrial fibrillation by the time they're in their 40s.
Yeah. So I think one of the key things that probably drives AFib in this population is stretch of the chambers. So in a perfectly healthy young individual with everything being normal, the pressure inside these upper chambers is almost a vacuum. It's very low. And there's not a lot of outward force being exerted by the blood on the walls of the heart in the upper chambers. What happens when something is different from that normal, from that ideal, is usually if there's some problem where the lower chambers are not able to very efficiently move blood forward, then there's sort of a traffic jam of the blood back above the lower chamber. And that leads to an increase in the pressures. So if there's a problem with the left heart, there's an increase in the pressures in the left upper chamber, and same thing for the right side. That increase in pressures causes the upper chambers to start expanding over time. The blood is exerting a force on that muscle, and the muscle is not able to exert an equal and opposite force. That's over a long period of time, that's going to lead that muscle to start dilating and getting bigger. That leads to the possibility for arrhythmias. Even if there's no scarring, if you try to go around a small area of obstruction, like a valve, it takes less time to go through a small path, and by the time you make that short trip, the muscle won't be ready to fire again. You don't usually have those arrhythmias. But when things get bigger, it just takes longer to make that circle, and the muscle fibers are more likely to be ready to fire again, and you will fairly quickly, suddenly, develop the ability to have these arrhythmias. For the patient who has had atrial fibrillation multiple times and has had multiple ablations, and they still have atrial fibrillation, I really would say that this is a time when we have to really strongly consider a different approach. And this is where I think a surgical ablation is clearly a very reasonable thing to consider. For the patient who asked the question, it wasn't entirely clear if he had ablations for AFib or flutter. And here the details do matter. If you had a AFib ablation and afterwards you really only have flutter, This is something that is usually fairly amenable to catheter procedure. But if you're having AFib, and many patients with hypertrophic cardiomyopathy will have AFib, more so than flutter, and you've had multiple ablations already for AFib, I really think, probably even after 1 or 2, we really need to start involving a surgeon in discussing the treatment options and expanding our horizon as to what we can do. You might want to maybe discuss what are the surgical options for that patient, maybe.
Well, if the patient has not had a surgical intervention before, then a minimally invasive approach is usually very feasible, and we see those patients and they do quite well. The cardiomyopathy does not interfere with the surgical ablation, and it really doesn't matter even whether the ejection fraction is 20% or 60%. This is done on the beating heart without stopping the heart, so it's rather straightforward, and it's done through incisions that are small with ports. If we go to my screen, I'll show you just a little snippet of what it looks like. I'll start my video here. Mr. and Mrs. Producers, if you can go to my laptop. I think it's best just to show what it looks like. We ready? All right, there we go. So this is a port. It's about as big around as the tip of your thumb. And through this port, we can see the heart very clearly. So everything that we do, we're looking directly, as opposed to the catheter ablation, which is based on a beautiful electrical map. We do some testing, but we rely more on the anatomy that we see. This is the heart sac, and if we advance this a little bit, we can open this heart sac. All mammals have a heart sac, whether you're a rabbit or a squirrel or a human. We have to open the heart sac surgically to get to the heart. And this shows the heart, and we're testing the heart, and we're stimulating the ganglionic plexi, and there's one right there, and you get really a ventricular diastole. So we also check for the nerves, and that's sort of the wild card in all this. It could just be, as has been mentioned very beautifully, distension of a hollow viscus. There could be some interplay of the autonomic nervous system too. So one of the advantages of the surgical approach, and there's another ganglionic plexi right there, is we can test for the nerves that innervate the heart and isolate these nerves, which are on the outside of the heart, not the inside of the heart. So this shows the clamp that creates the ablation. This is similar to a catheter ablation, although it's from the outside in instead of the inside out. We're around the pulmonary veins, and that's fairly straightforward. And the hypertrophic left ventricle does not interfere with this sort of procedure at all. We can also look at the left side, and that's shown here. The first was the right side. It's a similar incision to open the heart sac. And when we hit a ganglionic plexi with stimulation, we can see that there's some nerve involvement here, and we can isolate those nerves. And then lastly, the ablation is done on this side like the right. And then lastly, there's been a lot of discussion about the appendage. This is one other way that it can be treated. Now, if the patient's had previous surgery, it's a lot trickier. It depends on where their surgery's been. But this shows, this is a case from here at DEBAKEY, Houston Methodist. This is a patient with atrial fibrillation, and here we're surrounding the base of the left atrial appendage. The left atrial appendage is right here, and this is called an AtriClip. It's really like a hair clip, only a lot more expensive, but it works the same way as a hair clip. And now we put the clip on the base of the appendage. Now the blood in the appendage is isolated from the rest of the heart. Similar to a Watchman, with one difference being that the AtriClip provides a electrical isolation too, where the Watchman does not electrically isolate the appendage. But these are some options in this sort of 62-year-old male if that person has not had previous surgery. If they've had previous surgery, we can still do it, but we have to look at the old operative note and make sure the area that we're going to work on is accessible.
Great, thank you. So then there was a second question that came in through our audience, and that was about atrial fibrillation after ASD closure. So I believe they're talking about transcatheter ASD closures. And at this point, you and I have shared a few of these cases at this point. Can you talk about what would be sort of our optimal way of treating these patients, and maybe any theories you have about what's actually happening in these patients?
Yeah, it's an important thing to understand before we talk too much about that is there's a membrane, not quite well seen here, that separates the right upper and right lower and the left upper chambers of the heart. And thank you. You can see it over here. Most of the time when we're dealing with arrhythmia procedures that we do from the groin, we go up into the heart through where blue blood goes, or where veins are, and we usually end up in the right upper chamber of the heart. To get to, if we need to get to where the left side of the heart is, to where arrhythmias often are, we have to usually make a small hole. This is a place where everyone with a normal heart actually already had an atrial septal defect. Everyone had a hole on the day you were born. That hole that people are normally born with closes up very quickly, but there was a hole there. There's a very thin membrane there that we usually are able to cross very easily. Now this is something the procedure has evolved over the years, but it's been done for over 50 years. The procedure, as we do it nowadays, we have an ultrasound directly in the heart, a centimeter or two away from where we're poking. So we can see with very, very good clarity exactly where we're going to cross. And nowadays, we can really pick and choose where we want to cross very, very, in a very controlled fashion. This is important. When people have an ASD closure, if they're closed with an ASD surgical patch, sometimes over decades the surgical patch gets fairly calcified. It becomes almost like bone, and it's fairly difficult for us to cross right there. But it's almost always the case that there's going to be some rim of tissue around the surgical patch or the closure device that we can get through. In rare cases, we're actually able to get into a vein of the heart called the coronary sinus and poke up into the left upper chamber if that's needed, and that's the only other option. But we're able to precisely locate where we want to cross nowadays through the improvements in intracardiac imaging, so that we can usually get around those closure devices. Or even if the closure was done with a disc-like device deployed through a catheter in the groin, sometimes we can actually go through it, and sometimes that's reasonable. Even if the surgical patch was extensive and the original ASD was huge, and there is no way to go around it, most of the time when we go through these types of membranes, the hole we make closes up. In Fontan, some patients who've had the Fontan's corrective surgery, we wind up having to go through something that was originally Gore-Tex, and after 10, 20 years is now calcified Gore-Tex. That's not fun to go through, but we can, and we do, and sometimes we have to use special tools to get through it. So it becomes more challenging, but it is very much doable if we need to. What drives the process is really a little bit hard to say. I think when you have an ASD, an atrial septal defect, a hole in the heart, it does change a lot in terms of certain chambers of the heart are pumping more blood than they're supposed to be pumping because they're pumping some of the same blood again that they had just pumped. And that drives a lot of secondary downstream changes, including pressures in the heart, probably almost certainly autonomic changes. I think that if we can get to those patients before the closure is done, that's always nice. If we have to deal with it afterwards, most of the time we're able to get there if we need to. And the last thing I'll say is we can still do catheter procedures in some people who need us to get to the left side of the heart, but we cannot cross that membrane. And there are magnetically guided, very flexible catheters that we can go up into an artery, into the left lower chamber, up through the mitral valve, and still steer that with these massive magnets that are movable that go on either side of the patient's body. So there are options for those patients.
And then I guess to flip the question on its head, sometimes we've had situations where after we do the transcatheter ASD closure, a patient actually develops atrial fibrillation within a couple of days after the ASD closure. And so I guess, do you have any thoughts as to why that happens, even though it's rare, but...
Yeah, it's really hard to say. You know, one thing we know is that many manipulations in this area of the heart, or anywhere in the heart, can lead to AFib in the short term. For 50, 60, 70 years, people have known that after any valve surgery, bypass surgery, almost any heart surgery, there is this phenomenon of AFib afterwards that tends to disappear after about 3 months. And we blame inflammation, and it may be just inflammation, it may be a little bit more complicated than that. Catheter-based procedures are not entirely immune to this. When we burn in the heart, when you put something there that's poking at various areas that's a foreign body, this potentially could be creating that. There may be an edge of the device that's poking at something initially that's causing some extra beats that somehow triggers AFib. We don't really know exactly, but if it's the kind of AFib that comes and goes goes away after a few weeks and months, I'd say we're creating some inflammation or irritation that is transient.
Yeah. And so I think when we've worked with some of these patients, our experience has been to treat the atrial fibrillation, so to try to get them to restore sinus rhythm while anticoagulating the patient to prevent the stroke risk during this period of going in and out of atrial fibrillation. Not that we have a whole lot of data for that. So to emphasize, we don't really know in a post-ASD closure patient whether or not they are at higher risk for stroke. We just make that presumption. And we think probably being more aggressive with the anticoagulation, and therefore more conservative about their stroke risk, is probably the better way to go. So in some of our experiences, what we've done is we've put them on amiodarone for a short term until we are fairly certain that AFib risk has gone away, and then of course we monitor them thereafter after we stop the amiodarone and then consider discontinuing the anticoagulation, and typically that's a direct oral anticoagulant. We have had some experience with flecainide, for what it's worth. It's gone okay. We haven't been super excited about doing that. I think there's always some degree of risk of using things like flecainide, so we try to avoid that. We have not yet. There was a specific question about using digoxin in that scenario. What are your thoughts? I'm not super excited about it, but what do you think?
Digoxin is a very old drug. It's one of the oldest pharmaceutical agents that people developed, and it is a couple of things. It's a drug that probably has a small role to play in patients with certain types of heart failure. It's a very useful agent sometimes to slow the heart, but it is not an antiarrhythmic drug in the sense that it doesn't prevent a person from going into AFib, it doesn't prevent a person from going into flutter, and it doesn't accelerate the process of getting them out of those rhythms. It does have sort of what we call a low therapeutic index, which is you can go from a safe amount to an unsafe amount with a fairly small change in dosage. So it can go from being a good drug to not such a good drug fairly easily. So I'd be careful about it.
I can answer that top question. It says, does the Minimaze have a role in this? And I see patients from around the country that for one reason or another have an ASD device, and they do quite well with the Minimaze. We've done quite a few. Yeah. More than I can count on my two hands. I'm not sure, probably 30 or 40 patients that have ASDs that were placed percutaneously.
Right. Yeah. I think the Minimaze is something to really keep in mind for a lot of these patients when they have never had a cardiac surgery.
Right. That's
right. One of the key things here is if you've had a surgical corrective surgery, that tends to create enough scar tissue inside the chest around the heart. The sac that the heart sits in gets sort of glued onto the heart, that to then go back in again to do another surgery, it winds up increasing the complexity of that procedure quite a bit, I assume.
I've done about 30 true redos. It really depends on where the surgery was done. If it was done primarily on the aorta and not the back of the heart, that's been fine. If it was primarily intra-atrial, that's not a good situation.
Yeah.
Great. And then So I think the other question that I wanted to answer was there was a question about the anticoagulation in this scenario. So I feel pretty comfortable putting them just on direct oral anticoagulant thereafter, as opposed to putting them on dual antiplatelet therapy plus direct oral anticoagulant in the immediate post-transcatheter ASD closure period. I don't know if you have any thoughts from that standpoint.
Yeah, I mean, we have a lot of comfort level with blood thinners in general, but we also have some concerns with mixing and matching too many of these together. So I kind of agree. And a medicine like one of the newer oral versions of blood thinners like apixaban and rivaroxaban and edoxaban and those types of drugs are very reasonable in that situation with dabigatran.
So we are almost out of time, so I wanted to turn it back to Tom and see if he had any other thoughts or questions to pose to our august panel.
Yeah, I had one comment, and that is that this really, from the patient's perspective, this really is a journey. You do not know at the start of the journey what all the stops are going to be. And I know the earlier question about that a viewer had 3 ablations that didn't work. I think you have to look at each ablation as a stop, but you don't know if it's going to be the last stop. And if you're enterprising, the Heart Rhythm Society, you can search that in a web browser, does have publications such as a guideline for the management of patients with atrial fibrillation. And that's like a triptych for this journey. And I read that with a medical dictionary a long time ago. And I came to recognize that Dr. DeVay's treatment options and plans for me were following guidelines. And as a result, I got an understanding of not only what he was asking me to do or medicine he was prescribing, but that which he wasn't, and somewhat why. And so you are on a journey, and your doctor is the tour guide. And just remember that you don't know where it's going to go. My journey is probably not over. I wish it were, but I can't say that. So.
There's a quick question at the top. Defibrillator pacemaker implant interfere with the Minimaze? No, it does not.
Well, Mr. Erdos, I really appreciate your help over here, and your input here has been the critical part of all of this. If you were talking to a version of yourself from 6 years ago, what would you tell yourself? Reading that is fairly dense reading, by the way. I don't want people to leave with the idea that my patients have to read the guidelines for AFib by themselves. But I really will tell you that you've been an amazingly self-educated and motivated patient to have, and it's been incredibly gratifying and helpful. But what would you tell a version of yourself from the past, before all this began?
Don't gain so much weight. It's been the hardest part.
That's fair.
And I mean, there's not much I would do differently. I put myself in the situation through ignorance. And, you know, but it's more, the ignorance occurred much more than 6 years ago.
Yeah.
I've been on this process now since 2014. And, I would do again, I deal with scientific and technical issues in my career. So reading a technical document it's not out of the realm of what I do. And so self-education, I think, is important. But to the extent that you can, I think that that's what we should do.
Yeah. Well, thank you so much. And Dr. Wolf, and Dr. Lynn, thank you.
Yeah, so we've just scratched the surface for arrhythmias in congenital heart disease. We will continue the conversation on Saturday morning at our Adult Congenital Heart Symposium. So if you have additional questions or you want to hear more about this, join us then. Thanks, team, for a wonderful discussion.
Thank you.
Thank you.